Hello, I'm Rachel Babin from oncologynews.com.au, proud producers of the Oncology Journal Club podcast. In today's special episode, Eva Segelov and Craig Underhill talk to Professor Raina MacIntyre about COVID-19 1 year on. If you're not familiar with Raina, she heads the biosecurity program at the Kirby Institute. The next 50 minutes is packed full of information, covering a wide range of topics, including PPE and moral injury, the different COVID variants, and why vaccination is our only exit strategy. It's very refreshing to hear one of the world's leading pandemic experts speak at such length and so openly, so thank you, Raina. I hope you find value in this episode. If so, please do share the link with family, friends, and colleagues. This episode was recorded on Sunday the 6th of June 2021, so this is a very fresh look at the current pandemic situation both in Australia and globally. However, I am mentioning the date as the situation is still changing so frequently. For regular news and podcast updates, subscribe to the Oncology newsletter on oncologynews.com.au. It's free and it's a great way to support the OJC. This is Rachel Babin, and this is the Oncology Podcast.
G'day. Well, COVID 1 year on, and it's a great pleasure to again welcome my very good friend and a very good friend to all of the Australian people and Australian cancer patients because of her leadership during this pandemic, Professor Raina MacIntyre. Hiya, Raina.
Hi, Eva.
Raina, you've had a very busy 12 months, and what I liked the most was your recent appearance in the Archibald Prize.
Yeah, that was an experience. Went to the opening on Friday. That was really fun.
Fantastic. I've had lunch with Peter Wegner, the winner. I should have bought one of his paintings. He's a lovely guy. But I loved your painting. It was beautiful.
The painting was amazing. So congratulations. It would have been fun to be involved in that, I'm sure.
It was, yeah. It was an experience.
Great. Well, Raina, we wanted to catch up with you just for our listeners to have an idea, because there is just so much information coming through. And, of course, so much has happened, and it's even different in different states of Australia, as you know. So are you able to give us just a general update about COVID in Australia and globally? Where are we 1 year on?
Yeah, so 1 year on, we're in a much better position in one sense that we've got multiple vaccines available. The bad news is, of course, there's still a supply problem. There's limited supply in most countries, including Australia, and I think that will change as more and more vaccines come on board, and as big countries like the US get fully vaccinated, then some of those supply problems will ease. On the other hand, we've had emergence of variants of concern, from the UK or Alpha variant to the South African or Beta variant to now the Delta and Kappa variants that have been causing outbreaks in Australia. These are the ones that have risen from India, and they've got both increased transmissibility and some degree of vaccine escape, which makes it more challenging, but particularly in a country like Australia that has very low vaccination rates. The other thing about the Delta variant is it seems to be affecting children more, and there's more outbreaks in schools being caused by Delta. That also then puts the pressure on to formulate policy about vaccination of children.
And just a quick update, Raina, for us around the globe. We're seeing some third, fourth, fifth waves, but generally, do you think it will go down from here?
In some countries, certainly, in Israel, in the US, the UK probably, although the UK is struggling with outbreaks of Delta at the moment. But there's other countries which don't have as good access to vaccines, and where I think we'll continue to see a lot of COVID for a long time. So there'll be strongholds of disease, I think, persisting in the world for many years to come. That'll be like the travel hotspots that we'll have to be careful about. It just highlights the importance of vaccinating the whole world. it's in everyone's interest.
That sort of sounds a bit political, and of course there's been so many politics in with this. What about these whole concepts of eradication versus suppression, say in Australia or other countries? Are they still sort of current concepts?
Well, the whole debate about suppression and elimination in Australia has been a bit amusing, really, because there's been an argument about suppression and elimination. Suppression's kind of a made-up term that's just emerged during the pandemic. Elimination is a technical term. But in actual fact, what all states and territories and the federal government have pursued is elimination, which is zero COVID. That's the truth of it. There's a realization that it's not going to be politically acceptable to have anything else here. The technical term eradication means it's gone from the whole world. And smallpox is the only human-to-human transmitted infection that's been eradicated through vaccination. And elimination means getting rid of sustained community transmission in a region or a country. So, for example, we've eliminated measles and polio in Australia through vaccination. We get small travel-related outbreaks of measles sometimes, and that's because people who are susceptible might travel, pick it up overseas and come back in and set off an outbreak. But it never takes off and causes a huge, massive epidemic. They're always small, self-limited outbreaks because we have herd immunity. So that's kind of the situation we may have in the future with COVID, that high-income countries might have high rates of vaccination, and we may see occasional travel-imported outbreaks of COVID. They won't take off in the way the Victorian second wave did.
Do you think, Raina, right now, where we are, we've had, I think it's 19 or 20 cases in Australia reported today, 4 in the community in Victoria, the rest in quarantine. It seems like the Victorian government is again aiming to get to zero COVID. Is that going to be possible, do you think, with these variants and with the number of people in quarantine, with the risk of further outbreaks? I mean, where do you think we're at in Australia now? Are we going to be able to get to zero again, or are we just going to have inevitable outbreaks until we can vaccinate everybody?
I mean, I think with the current outbreak, we can get to zero, and the Victorian government is doing a good job. When you look at the numbers staying in the single digits for a prolonged period of time, that's very similar to what we saw in New South Wales last year with the bigger outbreaks that we had through June, July, and then towards Christmas. So that just suggests the whole infrastructure for contact tracing and testing, etc., has improved substantially in Victoria, and they're able to chase it down and stop it really taking off. We're not going to be able to stop outbreaks from occurring through hotel quarantine. That's where they're going to come through, but we can do a lot better than we have done. And one of the reasons is the denial of airborne transmission, which is Australia has probably been one of the most recalcitrant countries in acknowledging airborne transmission. The WHO kind of led the whole world in denial of airborne transmission, but even they acknowledged it by June 2020. But Australia has been, unfortunately, one of the strongholds of airborne denialism, and therefore, if you don't acknowledge how something spreads, you can't fix it. So we need to actually be selecting quarantine venues based on the adequacy of their ventilation, which isn't being done, where you actually test, if it's going to be hotels, you test the hotels for their ventilation, and that's fairly cheap and easy to do in a proxy way with a carbon dioxide meter. If it's inadequate, either it's not selected or you see if there's some mitigation that can be done. For example, if it's generally well ventilated but the corridors or elevators are a risk zone with poor ventilation, then you can put in portable air purifiers in those areas. So those are the things that can be done and would make a bigger difference to stopping. The other thing, of course, is giving all quarantine staff a respirator rather than a surgical mask, which is happening I think it's happening in Victoria now. And it's just really sad that, I think on a political level, there's been recognition that this is important, and we've seen the gradual shift in around quarantine, but not so for healthcare workers.
Healthcare workers around the globe have really suffered in this pandemic. Is it also for the same reasons in other countries?
Yes, I think so. It's partly been shortages, poor planning, not stockpiling enough, or nowhere near enough, and not, ramping up production. That was something we saw in the US, where they could have used the Defence Production Act last year to start repurposing manufacturing to make medical equipment, but they never did it. So, we had healthcare workers turning up during the absolute peak of pandemic activity in cloth masks.
Yeah, I think there's still a risk, isn't there? Because our hospital, the Victorian hospital system, went to a code red COVID alert during this outbreak, but there was no N95 masks required to be wear. So it was surgical masks and face shields, but I would have thought that it made more sense to escalate to N95. And one of the cases in Victoria today was another worker in the aged care facility. I'd be curious to know what PPE she was wearing, looking after at-risk patients.
Yeah, I don't think there's been as much focus on aged care or the disability sector for that matter, in the sense that the workers have just been left unvaccinated. There hasn't been an urgency or a plan, or even though that the workers in aged care and disability are listed as 1A, they've just been forgotten. And you have to wonder what's going on here,
Yeah, terrible. I saw out of close to 30,000 residents with disability in residential facilities, close to 30,000, there's 300 have had their first dose of a vaccine. That's a terrible situation.
There clearly is some kind of unstated prioritization of human beings in 1A based on, how deserving they should be of vaccination. That's what it seems like to me. Quarantine workers got it straight away because everyone recognizes, every politician recognizes that's where it's going to come from. But if it comes from there and comes in causing outbreaks, the outbreaks are going to occur in healthcare and in aged care, especially in aged care. And it's the workers who are going to bring it in, and the workers who are going to be potentially moving it around facilities and outside. So, it's a really high priority to vaccinate the workers.
Has that been done in other countries? Has that been recognised more? Or is it the same issue?
No, it's been done in other countries. Aged care workers have been vaccinated. There's a lot of literature on outbreaks in aged care. I've been involved in research on influenza outbreaks in aged care since about 2005. So, 15 years plus we've worked in this area, and it's well known, that you have to vaccinate the staff.
So there's lots of ethical issues that come up as well if staff don't want to be vaccinated, or whether they need to declare if they're going to be vaccinated, or potentially ethical issues. Some might see it as black and white. What's your view there?
Most states have mandatory vaccination laws for healthcare workers in different formats. That doesn't mean they hold you down and jab you by force. It means that you have to prove your vaccination status, and if you're unvaccinated, you're not allowed to work in certain clinical areas, or if, depending on legislation, if there's an outbreak, you can't work. So I think in those kind of industries where the stakes are so high, it is warranted to have mandatory vaccination, in the sense that it's not forced vaccination, but it's mandatory, which is an important difference.
Oh, thanks for that. Yes, the nomenclature is very important in this disease, and all sorts of people bandy all sorts of terms around that are not necessarily the same, perhaps, between the experts and the lay public and politicians. Have you found that to be an issue?
Yeah. There's, 20,000 experts out there who use all kinds of terms in all kinds of ways very authoritatively. So, how can you expect the public to keep on top of everything?
Indeed. So let's now go to the situation with cancer patients and what has been learnt worldwide in terms of cancer being a risk factor for poor outcomes, more severe disease and higher death for COVID.
There is evidence that cancer patients, particularly those that are immunosuppressed due to the medication they're on or the treatment they've just had, are at greater risk of poorer outcomes. They're also less likely to respond to vaccination. So, but I think it varies by the type of patient and what their status is immunologically. So if they are immune competent and their cancer has been treated in the past, but they're in remission, that's different from someone who's on, chronic ongoing treatment that results in some degree of immunosuppression. So I guess classifying patients in categories of immunosuppression and formulating policy accordingly is important, but they are vulnerable, and the vaccines are not equal. They do have differences in efficacy and immunogenicity, and there have been studies showing that certain types of cancer patients do not respond as well.
So, Raina, clearly we need more research, and that nicely segues to our upcoming research study looking in detail at serological and immunological responses of cancer patients to the vaccine. I do think there will be subtleties that will emerge from that, because not all cancer patients are equal, and we have very little data of vaccine response for patients on immunotherapy or really defining which subgroups. So exciting to do that upcoming research with you, Raina.
That you need to categorise patients by degree of immunosuppression, depending on whether they're currently on chemotherapy, whether they've had some kind of ablative therapy, whether they're on chronic immunosuppressive drugs, or whether they're recovered and immune competent.
Do we have data now on the efficacy of the current vaccines in cancer patients?
There certainly are studies on the immune responses, the immunogenicity of the vaccines, and they are lower for people with some kinds of cancer.
In the broader population, or is it just uncertainty because the variants of concern are new about how well the current vaccines will work, or do we have more robust data now?
We've certainly got several published clinical trials of the vaccines, and the efficacy does vary from sort of in the 60s to mid-90s% efficacy against symptomatic infection. Unfortunately, most of the trials use symptomatic infection as the primary endpoint, and that's because I think at the time the trials were being designed, which would have been early last year, it wasn't really appreciated how important asymptomatic transmission was in this infection, which it is. It's a major part of it and why it's so hard to control. We're stuck with these trials that give you this endpoint against symptomatic infection, but that doesn't actually tell you whether you can achieve herd immunity, for which you need, efficacy against all infection, or, if you've got asymptomatic infection and asymptomatic infection is as contagious as symptomatic infection, then that's not going to help with transmission. So there are some big differences there. The AstraZeneca vaccine is about, on the intention to treat analysis, 63% efficacious against symptomatic infection. If you space the doses out by 3 months, it goes up to over 80%. But the efficacy against asymptomatic infection was about 22%. So not good against asymptomatic infection. The Pfizer in the clinical trial, 95% efficacious against symptomatic infection. They didn't present the data on asymptomatic infection in the trial, in the main trial, but from post-licensure studies in Israel, it looks like it's 92% effective against asymptomatic infection. So a big difference. So if you really want to achieve herd immunity, that's the kind of vaccine that is more likely to get you that endpoint. However, there have been some studies, the last one I saw was actually on Pfizer, that shows that even if you are fully vaccinated and you develop infection, the viral load is less. That means that even though AstraZeneca is 22% effective against asymptomatic infection, if it reduces the viral load in people who do get infected asymptomatically to such a degree that they're not going to transmit, then it may end up having the same effect. We don't know, and I think we have to really look at the real-world studies. The only country that's really achieved a high vaccination, 2 countries have achieved high vaccination rates and have been using AstraZeneca as a component of their program, and that's the UK. Also the Seychelles. The Seychelles, one of the Chinese vaccines, the Sinovac and AstraZeneca, they use slightly more of the Sinovac. AstraZeneca was just under 50%. But in the Seychelles, they still had a surge in the epidemic, even though 70% of adults were vaccinated. In the UK, the percentage of the older adults is quite high, over 70%. The problem in the UK, when you rely on the AstraZeneca, it takes 3 months to become fully vaccinated. When you're using a vaccine like the Pfizer, it takes 3 weeks to become fully vaccinated. If you're vaccinating against a disease like polio, of which there isn't a lot around, there's not great big epidemics going on, that difference won't be that important. But in the middle of a pandemic, that difference actually is important. And that's what we're seeing in the UK. We're seeing these outbreaks of the Delta, largely vaccinated and partially vaccinated people who've had 1 dose. And the data that came out of the UK also showed that for both the Pfizer and the AstraZeneca, 1 dose resulted in 33% effectiveness. But 2 doses raised that to 60%, just under 60% for AstraZeneca and 88% for Pfizer. So you've really had to be vaccinated with 2 doses to get protection against the Delta.
I think some of these subtleties are lost in discussions where we're just told they're all equal. So are those subtleties important for cancer patients, or should we just be sticking to the message, get any vaccine you can? What's your opinion there?
Look, I think we're in a situation where there is a shortage of supply. There are outbreaks happening, so definitely people should get vaccinated. They need to get vaccinated with any vaccine they can get. But from a policy perspective, something's been amiss in not thinking through these issues properly.
Can I also bring you back to this issue of symptomatic and asymptomatic infection and really talk about the longer term consequences of COVID, which is something that occasionally gets some airtime, but there is a general feeling in some places that as long as people aren't dying of COVID, everything's fine. So can you bring us up to speed with this, the long COVID and the ongoing problems? I think a recent publication looking at readmission rate after admission for COVID showing that was extremely high.
So, the long COVID isn't necessarily related to the severity of the initial disease. So people with mild infection can still get long COVID. And some of those effects, sort of neurological, cardiovascular, etc., can occur in people who had very mild infection. So there's been, for example, cases of cardiac function impairment, heart failure, etc., in young people who had very mild respiratory illness. And I think the other point is we don't fully know yet the long-term burden of disease, but I suspect countries in Europe, in the UK, in the US, etc., are going to have a huge burden of chronic disease that we're only going to fully appreciate in the next few years as time goes on and the health system starts to see the effect of the chronic impacts of COVID. It really is the infection that keeps on giving.
Yes, not in a nice way. The other thing that worries me, Raina, is that the impact on the healthcare workers, I think certainly the Twitter feeds that I follow, there are people who stuck around in the healthcare system in places in the middle of the great surge in the UK and the US, but they're exhausted and they all plan to leave sort of once it's over in inverted commas. But I think we're coming up to a very exhausted workforce that will be drained of many people. Do you have any information on that?
No, but I think it is going to be a problem. There's also this issue of moral injury, which our colleague Michelle Ananda-Raja has written about, and their organisation, Healthcare Workers of Australia, which is that in this way that the protection of health workers was devalued, undermined, and not made a priority, I think it was personally painful to a lot of health workers to have to feel like they were expected to come to work and sacrifice their lives for the greater good without any consideration for their work health and safety. This whole healthcare heroes narrative is really disingenuous because it's trying to glorify this devaluing of the safety of healthcare workers. If it had been any other industry, if you talk to occupational hygienists like Kate Cole, any other industry, you'd be prosecuted for not providing maximal PPE for your workers if it was mining, for example. But here we are, you can do anything you want to healthcare workers and get away with it.
Again, what about internationally? Because there was also a lot of cries for help.
This has happened all across the world, except for a few countries that started providing maximal PPE to the healthcare workers right at the start. Generally, they were Asian countries, China, Taiwan, Singapore, for example. They began providing PAPRs, respirators, etc., to healthcare workers right at the beginning. I think it was closely tied to denial of airborne transmission. So, the denial of airborne transmission was really important. The denial of airborne transmission allows you to justify denying respirators to healthcare workers, when in fact you're in a highly contaminated environment. The air is contaminated everywhere. There's been studies that show that even in a hospital room with 12 air changes an hour, you can isolate the virus in the air. And the evidence has been there, even for this virus, the evidence has been there, the science has been there, but there's been this recalcitrance. It's just really disappointing.
Yeah, I remember those first ads when it first started. It's like, you don't need to wear a mask, just wash your hands. Everything will be okay. And you could actually make it worse if you wore a mask, because you might contaminate yourself putting it on and off. So it has been very interesting. I think people are pretty worn out and pretty traumatised by the whole thing. And we've been pretty fortunate in Australia, but with the current small outbreak, there was very much a sense of stress at work about, here we go again, once more into the breach. It's pretty unhealthy long term for people, and you can see why people just, if they're near retirement or wanting a change, they're just going to go, I've had enough.
Not so much for hospital healthcare workers, but for community healthcare workers like GPs, it's been really difficult to get vaccinated. Many of them work in aged care, so they are in 1A. And I know so many GPs who could not get vaccinated. When they asked the aged care facility, they said, no, we're not vaccinating staff, which is obviously, a bad mistake. And then when they asked their state health authorities, they were told, no, that's the Commonwealth's responsibility. They should be vaccinating you. So they were really caught in this gap where nobody really cared whether they got infected or not. I mean, every GP should have been 1A. GPs are the front line, that's where patients go when they're first ill. They don't just rock up to hospital, they go to their GP. And I think GPs have really been hard done by in this pandemic.
So I'm going to pivot to another consequence of the pandemic, and that's this issue of delayed or absent cancer diagnoses during the pandemic. And we've got emerging epidemiological data of reduced presentations, partly because of reduced screening, partly because of lockdowns, and a lot of modelling to show that this will translate into patients presenting with more advanced disease. And I think those of us in clinical practice are seeing that now. There have been models of the impact of this on death rates down the track, and I would think this is not just a cancer-specific phenomenon. I think there's also great concerns about mental health. So how do we best balance these issues with keeping people safe in a pandemic?
Well, I think we need to be very flexible, which this did happen to a reasonable degree in Australia, being flexible, making telehealth much more accessible to specialists and to GPs. And I think that really helped. We actually published a study looking at a range of things in the pandemic, including access to, avoiding going to healthcare settings, and it's a real issue. I can't remember the percentage now, but I can let you know. But people definitely stopped going to, I think it was something like 40 to 50% of people reported avoiding healthcare facilities during the pandemic. We actually have data in that study on cancer patients, but we didn't specifically analyse it, so maybe I can go back and have a look at it. But I think also last year it was a little bit different in that it was so unknown. When I think about myself back in March, April, worried about the people in my household who were vulnerable, it was really unknown. Whereas we know a lot more now. So maybe that will make things a bit different. And especially if we can get everyone vaccinated as soon as possible, that should ease that issue around avoidance of healthcare.
We saw the same phenomena emerge this week. Our own hospital and hospitals around the state were reporting the EDs and the health services were in crisis prior to the outbreak. And then our hospital actually went into code yellow, which is an internal disaster to manage the workload. And then as soon as the outbreak occurred, the EDs for the last week have been running about 50% of the normal activity. So unfortunately in Victoria, we may see another little spike in those undiagnosed cancers should this go on for a period of time.
So, Raina, that leads us on to predicting the future, which you've always been 100% accurate at.
Not according to some critics.
So, Raina, predicting the future, I mean, there is a lot of data around, as you say, 1 year on. Do you think that there will be maintenance vaccinations, and at what sort of frequency?
I think it's likely we'll need booster doses, but the frequency is unknown at this stage. It may end up being 5 years, it may end up being 3 years, it may end up being annual. We really don't know. There's serological data so far showing that for the higher efficacy vaccines, it lasts, 6 to 8 months at least. Hopefully it'll be quite a bit longer than that. But the serology itself doesn't necessarily predict protection because you can get waning of antibodies but still have memory that can be activated when exposed to the antigens. So, and the T cell response is probably just as important as the B cell response in this infection. So I think we'll only know as time progresses when there's long enough follow-up. The other thing is there's now a lot of work on a universal coronavirus vaccine, a pan-coronavirus vaccine. And I think that may also, I think there's going to be more and more developments in vaccinology for this disease as we move on. So this is only the beginning, which is really hopeful, I think.
Why do you think it has had such a success in rapid development of vaccines? Do you think it's the mRNA technology, or do you think it's just the advance generally in methodology?
I think the technology has been there. We've had diseases like MERS and SARS before that. There was no commercial imperative to develop a vaccine. There was no urgency because it wasn't affecting large enough numbers of people and in very selected areas of the world. This has been different. The economic cost has been enormous. The healthcare cost, the cost in lives lost has been enormous globally, including in high-income countries. And so the collective will to do something about it has been, 1,000 times more than it's ever been for any other disease. Really, it's been unprecedented, the efforts to develop a vaccine. We've seen drug companies that normally are competitors collaborate on making vaccines. We've seen all these different companies coming up with vaccination, with donations from all kinds of philanthropic sources. The effort, the collective will, the collective minds that have been put towards it has just been unprecedented. And that's, I had no doubt that we would have a vaccine. Last year, this time, when all those people were saying we may never have a vaccine, I had no doubt, because really the efforts have been phenomenal.
And you said that on our Oncology Journal podcast. So for those listening, if you want to go back and hear Raina's prediction, go back to our original. We did several podcasts with you, Raina, about the vaccine, and it's been extremely helpful to us as cancer clinicians.
Another question about the future, Raina, we've seen a plateauing in the uptake of vaccines in the US and I think in Israel as well. So do you think we will get to a level where we get herd immunity? And if so, how long do you think it's going to take globally for us to get to that?
So country by country, it's going to vary. Countries like the US have a huge anti-vaccination problem linked to, specific cultural factors there. In fact, there's quite a bit being published in the medical journals on the link between disinformation state actors and disinformation campaigns against the US linked very closely to the anti-science agenda, anti-vaccination agenda. And, I think that's amplified an existing core of anti-vaccination that was in the US anyway. So they're going to have some difficulty. I think in Israel they'll probably get there. Australia has a really good vaccination culture and a good history of high uptake, really high uptake, amongst the highest rates in the world for both adult flu vaccines and childhood vaccines. So we've got the right kind of setting to achieve herd immunity. We just haven't had the plan. In Israel, we saw a determined plan. It was like, right, we're going to do this, we're going to do it fast. Understandably, in countries like Israel and the US, they were facing bad epidemics, so there was a push to do it. But, we've got just as much to lose, especially now with other variants coming in. I think it is possible, but the longer we wait and the more we allow variants to emerge, the harder it's going to get. You're going to need higher efficacy vaccines. You're going to need higher coverage. We need to be thinking about vaccination of children.
So, Raina, this week we're all listening to our big American meeting, ASCO, online, and everybody is posting photos of the halls in the day where there used to be 30,000 people sitting in the plenary and people just like a mosh pit trying to cross the bridge between the two buildings. And Craig actually ran a poll of when people thought on Twitter we'd be back in person. So what would you have voted?
The options were 2022, 23, 24, or who knows?
I think it's who knows, because I think the way we do things will change. Me personally, I'm really happy to not have got on a plane, for more than a year. I'm thrilled. I was so sick of traveling. I hated it, the idea of just, especially from Australia. If you live somewhere that's close to everywhere else, well, but even to go to Asia, it's like 9 hours, 8 hours. Everything's far from here. So it's a huge, big deal for us as Australians to travel. The carbon footprint, the cost, the time away from your family. I think I've always been a believer. When I was kind of getting fed up with lots of overseas travel, I always believed you could achieve just as much virtually as you could by going overseas. Obviously, the networking and stuff may not be as effective, but, we've found ways to network and catch up socially, virtually as well. So I think there will be some changes that persist, more flexible working, less travel. I think a lot of companies will realize that they can get work done maybe even more productively because people aren't wasting time traveling and commuting when they work from home, and people might be also happier because of the less stress of all those things like commuting and traveling.
But if you do travel, say on a cruise or even on a flight, do you think it makes sense to check vaccination status? And how comfortable should we be if we're on a flight and people have said everyone on the flight's vaccinated? Does that give us a false sense of security, or is that reasonable?
So planes generally have pretty good ventilation systems. I'd be more worried about a cruise than a plane because cruise ships do have quite explosive outbreaks, and you've got people together for much longer periods of time. And if you've got a seed of infection there, it can keep perpetuating. Often it's the staff members. You get people coming on a cruise for 2 weeks. There might be an outbreak, they might not. There might be a staff member who's infected. Those people get off the boat, other people come on. So it just becomes this vicious cycle. And we saw that with, some of the cruise ships that were affected last year. We've seen it with influenza for decades. Airlines, look, I think in the end, vaccination passports will be a thing. We have them for yellow fever. And I think in the end, my prediction is the kind of vaccine you had will matter. It may determine whether or not you have to go into quarantine or how long you have to go into quarantine or whether you've got to be tested, etc.
So having said that, given that we're probably going to need boosters, do you feel people will change between the vaccines and in the end there will be some winners and others discontinued?
If it does turn out we need a lot of boosters, like annually, the vaccines, there is going to be a difference between the vaccines. There's a problem with the adenovirus vectored vaccines because adenovirus vector immunity is a real phenomenon where the more you vaccinate someone, the more immunity they develop to the vector itself, which means that your body then fights off the vaccine when you're vaccinated. So adenovirus vectored vaccines are not the best for a vaccine where you're going to need an annual booster. So that may be a reason why that vaccine doesn't survive, won't be around in 5 to 10 years.
that gives us a very good segue into side effects and the issue particularly of clotting. We know cancer patients have a prothrombotic tendency, but to my knowledge, there's been no real link between the people who get the vaccine-related thrombosis syndrome and any pre-existing history of clots or predisposition. Can you update us, thanks, Raina, on that?
Yeah, that's right. There's no predictable risk factor. It's quite rare, sort of one, depending on the age group, 1 in 50,000 to 1 in 100,000. There was initially a gender difference and a feeling that it was more common in women, but that could have been because the initial data were coming from mainly healthcare workers who are predominantly female in the UK, but that started to even out as more and more people got vaccinated. It's thought to be due to the mechanism of delivery of the antigenic component, the DNA, and it's potentially something that could be fixed in the vaccine design. There's a couple of different theories about what about the vaccine causes it. It is specific to the adenovirus vector vaccines. It's been seen with the Johnson & Johnson and the AstraZeneca. The rate is lower in the Johnson & Johnson. Most of it's been seen after the first dose, but there have been some second dose reports. And again, that's probably because of the time delay between the doses. Interestingly, in Australia, the case fatality rate has been much lower than anywhere else in the world, and people are saying we're just great at managing it. I'm a bit more cynical than that. I think we really need to see the data on case ascertainment, how we attribute deaths from thrombosis, and what criteria are used to define whether it's related to vaccination or not, because there is a problem with the commercial HITS tests. There's false negatives for 2 of the most commonly used commercial tests. So if you're relying on a positive test, then that would exclude some people who actually do have the syndrome.
So overall, a year on, Raina, how would you summarise? We've learnt a lot. We've developed a vaccine. Really, politics and policy maybe has been more than science a problem, implementation. Are they all fair enough observations? What's your view?
Yeah, I think, unfortunately also we've seen a lot of just, the politics has been really disappointing in the sense of, squabbling between states and federal and trying to set up rivalries between states. And it's just crazy, we're all in the same position and we all want the best outcomes. So we just need to try and put aside the political sniping and just get on with it. Yes, some mistakes were made. They always are. No country gets it 100%, but we can learn from those mistakes and just move on, pick up and move on and get it right. It's really important because these variants have basically raised the stakes. So, the UK variant or Alpha was 50 to 100% more contagious than the variant that caused the Victorian second wave. And the Delta is probably at least 50% more contagious than the Alpha. So it's really contagious. If that really takes off in Australia, it's going to be much harder to control. And then it's also vaccine resistant to some degree. So in a country where very few people are vaccinated, that's, it's all a series of challenges that could leave us very vulnerable if there is a big outbreak. But the biggest problem, I think, is the supply. I think as soon as we can address the supply question and have a free-flowing supply, we can really ramp up the vaccination rates. But the rates of vaccination we're going at the moment are nowhere near what you need. We published a study on modelling study of vaccination for New South Wales, and you need to be giving at least 100,000 doses a day, ideally 300,000 doses a day in New South Wales alone, and we're nowhere near that.
I saw today we hit 2% in Australia, people with second dose, 17% overall. So I was looking at the league table and we've managed to get above Kazakhstan and Moldova and Equatorial Guinea, but we're still behind Bulgaria and Azerbaijan. So we're actually doing pretty badly with the rollout.
Yeah, and again, that's the choice of vaccines, right? If you look at the rate of vaccination and compare the US and the UK, so the US was using all vaccines that were either 1 dose or three weeks apart, right? And the UK was using Pfizer, which was 3 weeks apart, but the AstraZeneca as well, which is 3 months apart. The UK started off with a higher percentage of people with the first dose, but the US overtook the UK in fully vaccinated because they chose short spacing or one dose, right? So the US is ahead of the UK in fully vaccinated. And that matters in a pandemic. It doesn't matter if you're vaccinating against polio, but it matters if you're vaccinating against COVID-19. I think that's something that hasn't been appreciated as much. And even now, people in the UK are saying the reason we space the AstraZeneca by 3 months is you increase the efficacy. It gives a better response with a longer dose. So does the Pfizer, actually. There's been new data that's come out about the Pfizer that if you give it 3 months apart in very elderly people over the age of 80, that they get a better response. That's great, but if you're relying on a 3-month interval. So in the UK, they're saying that the trade-off between the delay in being fully vaccinated, given that your protection is pretty low after just one dose against the Delta, and the risk of Delta, that it may not be worth it, that it may be worth just shortening the interval and getting people fully vaccinated sooner.
Well, that will be interesting. Why doesn't everyone just go for the one shot? I mean, logistics, time, and just really ramp up the one shot vaccine then.
So the J&J, their primary endpoint was slightly different. It was moderate to severe disease, which means when they say it's, whatever percent effective, it's not it's not apples and apples. So it's probably similar to the AZ in terms of the efficacy against symptomatic infection. And I think 3 weeks is okay. If you've got a vaccine that gives you full protection after 3 weeks, that's okay in a pandemic. That's fairly short, but 3 months is a really long time.
So, Raina, it's been an absolute pleasure. We are humble oncologists and sometimes find all of this information overwhelming and don't always appreciate the detail. And so having your insights has been invaluable throughout this pandemic. And I really wonder what we'll be discussing in 1 year's time, hopefully not still in lockdown and not still with variants coming. But it's been absolutely fantastic. Craig, have you learned a lot?
So, Raina, you talked about, one of the upsides of the pandemic is being able to connect with Zoom and things. So it's been wonderful for me on a Sunday afternoon to dial in and listen to two, intelligent women having a chat about this issue. It's been great. So thank you. My take home was optimism in the future, but maybe a bit of a rocky time in the short to medium term. A few risks still for us to get through, but it's been very insightful. So thank you very much to both of you.
And, vaccination is our exit strategy. We just need to get on with it and get as many people vaccinated as fast as possible.
That's a very clear message. Thank you once again, Raina. It's been a pleasure.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.